good evening and welcome to the General Preventive Medicine Residency's Fall Grand Rounds. We're excited about this timely topic and the opportunity to have this discussion, and we're grateful that Congressman Sarbanes is available to be with us on today. Thanks to the sponsorship of the Mid-Atlantic Public Health Training Center, many of you are joining us online, so we encourage you to sign in and email your questions to maPHTC@jhsph.edu. For those of you in the audience, please on your way out sign in so that we can take account of your attendance with us on today. For those of you from the School of Medicine, the School of Nursing, and the undergraduates from the Intro to Public Health course, we're grateful that you too are here and trust that today's talk will spark your interest in public health overall and the program at Johns Hopkins in particular. So what is public health? Well, in fact, we are the second oldest residency in the United States. The program at Hopkins is actually one of the oldest and one of the largest programs. Our mission is to train physician leaders in domestic and international public health by adding the rigorous didactics of the MPH to 1+ years of clinical training. We also add a meaningful agency experience so that our leaders are able to accomplish the goal of public health, whether they are, again, international or domestic. To date, we have over 500 alumni who have robust careers not only in research, but in federal agencies, academics, and domestic and international NGOs. To introduce our Grand Round speaker for today, we have a physician who actually exemplifies all the attributes that we would like to cultivate in our residents. Though not a graduate of our program, Delegate Dr. Dan Morheim is my colleague in emergency medicine. For the last 30 years, he has served patients individually in the emergency department, but found that the challenges of the community needed to be handled more upstream. And in fact, over the last 15 years, has taken his practice of medicine to the Maryland House of Delegates. Now in his 15th year of service, Delegate Morheim is actually the Deputy Majority Leader and serves on the Health and Government Operations Committee. I now introduce to you a servant of the people of Maryland, a faculty member of the School of Public Health, and a friend of the General Preventive Medicine Residency, Delegate Dr. Dan Morheim.
Well, good afternoon, everybody. It's a pleasure to be here with you. And Marcia, thank you for the introduction. Marcia and I are dressed up today in nice clothes, but otherwise we have spent a lot of time wearing scrub shirts and white coats, working day shifts, night shifts, weekends, holidays in emergency medicine. And I think that frontline experience is what has inspired both of us as we both continue in clinical emergency medicine. I saw patients this morning, so much of what we would see in the emergency room we began to see had social antecedents, had public health problems, and if we're going to take care of those folks at 2 in the morning, we might as well try to deal with them during the daytime through sound public health policy. And I think wherever you go, for those of you who are thinking about a career in public health policy, it's a wide open field. It has a tremendous range of activities, and it's a great field to be in, and it's one you can really make a difference. And I do want to acknowledge one person in the audience. There are a lot of people in the audience who make a difference, but one in particular right here is Vinnie DeMarco, who is head of Maryland's Healthcare for All. Vinnie, stand up so everybody can see you. And you, in the last couple of years ago, we passed a major healthcare expansion bill in the state. Vinnie was absolutely instrumental in getting that done. But legislation is nice. What really is important is the follow-through. And we expanded Medicaid, and we've signed up, and largely through Vinnie's group's efforts. How many people, Vinnie? 50, 60,000 people who didn't have health insurance now have Medicaid. So that's a substantial accomplishment. It gives them the opportunity to get primary health care, to get problems attended to early, and so that they don't have to come to the emergency room late where I see them. But it's my pleasure now to take a few minutes to introduce our featured speaker, Congressman John Sarbanes. Now in the handout you can read all the details, the kind of objective curriculum vitae of Congressman Sarbanes, because he's had a distinguished career in private life and now in public life. And he went to Princeton, and he's a Woodrow Wilson School of Public and International Affairs student there. He had a Fulbright. I understand you went to Greece for that John, and I'm sure you studied all the time while you were in Greece with the Fulbright Scholarship. But that not being enough, he came back and went to Harvard Law School. After graduating from law school, he came back to his hometown of Baltimore, where he was born and raised, and he worked in a number of programs and projects, one being working for the Maryland State Superintendent of Schools and doing education outreach. And I know some of that has formed some of the policies that he's put into place. He's been a leader in getting children outdoors, dealing with something we call nature deficit disorder, and he's also been acknowledged for his other work in educational service. He then went on to private practice of law, in which he represented nonprofit hospitals and other nonprofit organizations and long-term care. Now, apart from all this, I want to throw out the part that's not in there. Congressman Sarbanes ran for Congress in 2006 and got elected. He got reelected in 2008. And he is my congressman, and I'm so pleased that he is, because he does such a good job in so many areas. But equally as important, we work together on federal and state issues. You're going to hear him speak today, but what he's really excellent at is listening. I've gone to him, many people have gone to him. He meets with doctors, nurses, healthcare practitioners, and he really takes in what they have to say, because he recognizes those who are actually involved in the delivery of care have something meaningful to offer. So we've discussed issues of healthcare information technology, access, and of course the bill that just passed the United States Congress. So Congressman Sarbanes is doing a fantastic job. I'm so pleased that he represents me, and he's just been as thoughtful and concerned and considerate in all his approach to these really very complex problems, taking it all in and then coming out with, I believe, very, very sound voting record and very sound public policy formulations. So with that, let me welcome up here Congressman John Sarbanes. I want to add one other thing. This is a plug. I run a public health policy series over at the School of Public Health, Hampton House. And last year, Congressman Sarbanes was our kickoff speaker, made quite an impression. And we have one more in our series this year, to which I'm all inviting you. That's this Thursday, noon, Hampton House basement. And we close this year with a lobbyist panel. We have 5 lobbyists who will talk about how to influence public policy. And also, no RSVP required. We have free catered lunch. So if you want good lunch, good conversation, good topics, please come. Congressman Sarbanes.
Thank you. Thank you very much. Thanks very much, Dan. Good afternoon. It's a privilege to be here. First of all, let me thank Dan for not just that introduction, which was very generous on all counts, but the work that he's done for so many years. He's seen the importance of public health from all different sides and dimensions, and he's gone to fight for it in Annapolis, and his work there actually has been a model for me on more than one occasion when I've tried to gather up ideas and introduce legislation in Washington. So he's really an indispensable part of the Maryland scene when it comes to advancing the goals of public health. I also want to echo his salute to Vinnie DeMarco, who is kind of the health advocate extraordinaire of Maryland and beyond. And I've worked with Vinnie on initiatives at the state level, but also at the federal level as we've been putting together this very, very important reform bill. Let me tell you where we are in the process, just as an update, because you couldn't have picked a more timely session to kind of catch up on things. And I'm very sensitive to the evaluation form, which allows you to rate me as below average, average, good, and excellent. So I will do my best to at least stay away from the below average category. Here's where we are. Last Saturday, and what was probably the most exciting day on the House floor since I've been in Congress. I've only been there 3 years, but there's been a lot happening during that period. So even to claim that Saturday was the most exciting day, I think says something. I was able to cast my vote for the House version of the health reform bill. I did that with a lot of pride and with no hesitation. Notwithstanding that there are, it's not a perfect bill. There are things in there that I'd like to see change even as we go through the process on the Senate side. But on balance, This is a bill, when you go through it, when you comb through it, and if you have the time, you should try, particularly Division C, which is where many of the public health initiatives are addressed. It's a bill of about 2,000 pages, but when you work through it, you can kind of make a checklist of all of the accumulated grievances of the last few decades when it comes to our current healthcare system in terms of initiatives that are designed to address those grievances. And I would counsel you not to be overly distracted by some of the debate in the press that has gotten most of the attention. It's important debate on things like coverage and the public option and so forth, but it has actually distracted from many elements of the bill, including the ones that have to do with public health and preventive medicine and primary care that are really just wonderful, wonderful investments in a new healthcare system. And I view those of you who are going to pursue public health, who are focused on the preventive side of the spectrum of health services, as the ones that are going to craft the new healthcare system going forward. And thank God for it, because we've got a system now that is really focused too much on the back end, too much on getting people better once they've already become sick and often acutely sick, rather than investing on the front end, which is better for the patient, and all the research demonstrates, of course, is less costly over time to the system. We voted on that bill Saturday after a process of 3 committees in the House putting the legislation together. I serve on the Energy and Commerce Committee, which is one of the key committees of jurisdiction with respect to health. The others are Ways and Means and Education and Labor. That was a process that culminated after hearings beginning as far back as January. So we've spent 11 months on this topic, and it has really dominated much of our work in Washington. I think it was worth the investment of time and attention and legislative resources to do that, particularly if we pass the thing. That's going to make it all worth it. We brought the bill to the floor. We passed it on a very close vote, 220 to 215. Someone asked me the other day whether Nancy Pelosi, Speaker Pelosi, knew she had the votes at 5:30 on Saturday because she held a press conference asserting that she had them. And I said, well, let's just say she's a very good poker player, because I'm not sure we had them at 5:30, but we did have them at 11:15 when the bill passed. On the Senate side, of course, the process of melding together their proposals and coming to the floor of the Senate with their version of the bill hasn't yet happened. I hope that happens before the holidays. I'm not so caught up on the ultimate timeline here as I am that we continue to make forward progress. And I think that with us having passed something on the House side, if the Senate can do the same within the next few weeks, then we can have the assurance that the process continues to move forward, and then get to the conference committee, and from there craft a final version of this bill to be voted on in both chambers and hopefully passed and sent to the President for his signature. As I think was alluded to, I spent many, many years before I got into Congress working in the healthcare arena as an attorney, representing hospitals, physician groups, working with senior living communities, and other providers of healthcare. So I come from the provider perspective. I'm very invested in the notion that the provider should get the respect and attention and deference that the provider has earned given its place in the system. And I think that has been marginalized to a certain degree over the last few years. And we have to put the patient and the provider back at the center of the health equation, or else we're not going to be delivering high-quality care, and we're not going to be doing it in an efficient manner. Now, I just wanted to cover a few, this may seem a little bit random, but I want to give you some kind of framework issues to think about. The first is this question of our public health system. We had a hearing when I was in, I guess it was in the Oversight and Government Reform Committee, and we had a panel there to discuss the public health system in America. And when it got to me, I wasn't trying to be, a wiseacre, but I said, let me ask you this. Is the title of this hearing even off base? Can we claim to have a system of public health in America, particularly when you compare it to other countries around the world, where I think they've done a much better job of creating a real integrated framework that addresses public health? And taking my cue, the panelists one after the other said, yes, you're right, we don't really have a system. What we have is, we have some very strong examples, I think, at the local and regional level of public health officials and advocates and providers who've really taken this issue and created programs that we can emulate and can serve as a model. But the notion of an integrated national system of public health is something that has eluded this country. I mean, I can point to the efforts here in Baltimore of Josh Sharfstein, where I think he did a wonderful job, and of course, as a result of that, got plucked up and appointed to the FDA. I think Peter Bielenson in Howard County is putting together a very strong framework in terms of public health. And there's other examples, not just in Maryland, but across the country, of people who know how to do this. But we don't have a health system for the country. And that's where you come in, because I think you all are going to bring the innovation and the research-based perspective to make that happen going forward. So that's something to think about. A second thing to think about is, what is prevention? I think we sort of all, in this room at least, have an intuitive sense of what prevention is. I define it as doing things earlier on in the process, intervening earlier to avoid problems on the back end, and to create a more healthy environment for people generally. Once you start looking at it through that lens, there's many initiatives that start to fall within the ambit of that, including lead abatement in homes, so that people can live in homes without a fear of being poisoned, dealing with other larger environmental conditions which contribute to or detract from the health of the public. One of the most frustrating parts of this debate on health reform, I must tell you, has been the refusal of the Congressional Budget Office to give us what they call a positive score on prevention initiatives. One of the things I've learned really in this process is how much power the Congressional Budget Office wields. They develop sort of the fiscal note on any legislative proposal that is crafted. And they tell you what's it going to cost, what savings will it generate. And since the President was very clear, and the leadership in Congress took up his call on this, that we needed to keep the cost of this health reform bill at about $900 billion. Exactly what all the proposals cost and the savings they could generate and so forth became extremely relevant to the conversation. But it was maddening that we were given very little credit in terms of savings that went into the equation for the prevention initiatives, the many prevention initiatives that are contained within this bill. And you get a lot of double talk when you probe on this. When it comes to prevention defined as stopping people from getting sick, they say, well, it's not conclusive that that'll save the system money because they'll just live longer and then they'll consume more health resources down the line. I reject that proposition, but it can be elusive to prove it. The second thing they say is if prevention is defined as, for example, more testing on the front end to determine whether somebody needs a particular treatment, the cost of providing that testing across the whole population is such that it's not clear in the minds of the people that do this analysis that you're actually going to save money, because when you add up the false negatives and the false positives, it could be a wash. Again, What they're not valuing, I think, are models that demonstrate real savings. And of course, they're not really putting a value on the moral imperative of trying to keep individuals from getting sick in the first place, which to me is a real driver when it comes to the health reform process. So that is something else to think about. And let me tell you how real that is. I sponsored a provision to do more reimbursement through Medicaid of the services that are provided at school-based health centers. And they wouldn't give me the benefit of any long-term savings from doing that. In fact, all they gave me was the negative of a score for the services themselves. And it was premised on the notion that right now, even though we have the Children's Health Insurance Program in place, there are many children who are not receiving primary care health services. And this assumption is being made by the bean counters at CBO. So when I came forth with a proposal that was guaranteed to mean more children would access services to which they were already entitled, they gave me a score on that of an extra $15 billion over 10 years, the result of which was that provision was stricken from the bill because it took it outside of the $900 billion constraint. So that was very frustrating because that strikes me as such an obvious place to focus our preventive energies and could contribute to an integrated public health system across the country. There are 30% of the schools in this country who don't even have a part-time nurse. Now lay that statistic against the current H1N1 outbreak and our desire to have a comprehensive response to it, and you understand where the gaps in our public health system exist. Let me talk about 2 or 3 categories of initiatives that relate to prevention that are contained in the bill. The first relates to, and these are all things that I focused a fair amount of attention on. You have to kind of pick your spots when a 2,000-page bill is coming through the station. And I chose to focus on some of the things I'm going to mention now, which is why it's a real treat for me to be able to present to you today. The first has to do with workforce. As many of you know, we've already got significant shortages in our workforce, particularly among primary care practitioners. And despite this, of course, we are embarked on trying to provide more coverage out there to cover the uninsured, which is a noble aspiration and one I support 100%. But if we create higher expectations that coverage will mean treatment, and we don't then have the workforce in place to deliver that care, we're setting ourselves up for another train wreck, a worse train wreck than we may be in now, and sort of fulfilling the prophecy of critics that we're going to have a system that rations care because we won't have enough people to actually deliver it. So I have been very focused on that. There is a lot in this bill which is designed to support the workforce and getting more people into the pipeline across the board, but particularly with respect to primary and preventive care. Those are direct investments in public health, as well as loan forgiveness programs, training programs for primary care, residencies where you are, where the venue is a community health clinic, an ambulatory care center, going into some more of the non-traditional locations where you can really develop a primary care perspective. And we've brought all of those different incentives to bear to try to encourage people to choose that field of practice, recognizing how fundamentally important that is going to be going forward. Delivery system innovations. Another area where I think there's huge opportunities. So for example, I already mentioned the case of school-based health centers. We can do so much at the school level in terms of screening and preventive care and nutrition and other things that we know we will reap huge benefits from over the life of those individuals and for our system. But we really haven't tackled that in any kind of comprehensive fashion. There are many initiatives in this bill that do address that I'm excited about. We are putting a significant, billions and billions of dollars investment into upgrading our community health center infrastructure around the country, which is going to lead to more innovation and I think yield wonderful results in terms of the public health statistics that we'll start to gather from that effort. We've got efforts to focus on senior centers and other places where seniors gather and how to provide services there. In a sense, you have different kinds of captive audiences out there in the society, and if you can think about how to bring the healthcare system to those audiences instead of relying on those audiences to come to the healthcare system, you can get better results in terms of care and outcomes and also save a lot of money. And then there's a lot of things you can do around prevention in the adult workplace with incentives to businesses and employers to set up programs, fitness programs, nutrition, other kinds of things in the workplace, again, where you've got these people right at your fingertips. Payment is another area, obviously, that is important if you're going to encourage preventive care, primary care. And there are a number of initiatives. I got a whole list of them in my BlackBerry, so later when we have questions, I can go through them. But there's a number of initiatives that recognize that we haven't really been paying and rewarding our practitioners for spending more time on preventive care and primary care. And this has been perceived by the patient population. I talk to many seniors, for example, who lament the fact that they can't spend another 15 or 20 minutes with their physician, which they believe would lead to a better diagnosis and a more effective regimen being prescribed, treatment regimen. But the physician is not being compensated for doing that, and so doesn't have the incentive, and it's a fair calculation for the practitioner to make, doesn't have the incentive to provide those services, even though, again, the results would be better for the patient, and much of the research shows would lead to reduced costs over time for the healthcare system. So we got to look at how much we pay for certain things and whether we need to be recoding a lot of the ways that we reimburse. The federal government needs to model good behavior when it comes to that, because often the private commercial plans will follow behind the government and point to them as an excuse for practices that also don't make sense. So payment reform is also absolutely critical. And then broad education initiatives are going to be fundamental to shifting us more towards this public health preventive perspective. And Dan mentioned the No Child Left Inside initiative. This was my parody on No Child Left Behind. But it's not a parody. It's a very effective outreach in terms of environmental education. And the idea of it is, let's get our kids, let's have schools model the way in which kids can be brought out into the environment, into nature, because the research shows, number one, they learn better when you do this. Number two, their awareness of the environment goes up, obviously, with benefits for all of us from that. But number three, the public health benefits are significant, because you're getting kids active. You're getting them used to a kind of lifestyle and participation in their environment, which is going to hold them in good stead for the duration. And there is research now, and I'm sure many of you are familiar with it, that shows that the average young person spends 4 to 5 hours a day on the internet, video games, and television, and about 4 minutes a day outside in unstructured recreation. Well, we need a technologically savvy next generation, but we need some balance in the mix. So education at all levels is also a critical ingredient to a strong public health system, and we have to focus on that as well. There's a lot of research that we're going to be supporting in this bill. In particular, I point to requirements that we take into consideration recommendations on the task force on clinical preventive services, as well as the task force on community preventive services. And this all goes to a fundamental point. We have so much good data, research, studies abound on how to fix this healthcare system. But I will tell you, folks, that if we don't get in place a better framework for the healthcare system, a foundation that's strong and not rickety, we can't do anything without research. We can't build on the current structure with all the good information we have. That's what we're trying to accomplish with this healthcare bill, is to get a new framework in place where we can take all this good research and start to put together a different approach. And I'll tell you right now, just in closing, it's not that we are going to pass this on a Monday and that the President's going to sign it on a Tuesday, and then on Wednesday we've got a great healthcare system. This is going to be a long haul. But if we don't pass this and the President doesn't sign it, we haven't got a prayer of getting to a new healthcare system and to a better healthcare system. And that's why, despite all of the toing and froing and, you know, surviving the winds of August, town halls and so forth, I'm quite unrepentant in my advocacy for this bill, because I think it's going to make a tremendous difference for millions of Americans, not just the ones who are uninsured, but frankly, many who are insured, who are paying more than they need to, who confront abusive practices within the health insurance industry that, you know, make our hair stand straight up. There's a lot of people who have a stake in us getting this done, and that's why I'm going to keep working as hard as I can over the next days and weeks, and hopefully not months, to make sure we bring this home. So thank you all for the opportunity, and I'll open it up to questions.
As the Congressman has been gracious enough to accept questions from us, I'd like to encourage you to use the microphone. We have folks who are standing on either side. Because we do have a web-based audience, if you could wait until the microphone comes to you, I'll acknowledge you, and then you can start asking your questions, okay?
Hi, my name is Alifia Maswal. I'm a resident here in the General Preventive Medicine Residency Program. And I just wanted to learn more about what sort of initiatives are in the Congress bill in terms of changing payment to physicians. Mm-hmm. I know you alluded to
Well, let me give you a
in
couple of specific examples. Right now, there's a whole slew of interventions, treatments, that you would characterize as preventive services in the Medicare program, for which there is a co-payment obligation. So one of the things that we're going to do is eliminate that cost sharing for a whole category of those kinds of things in order to encourage them. Initial exams, which now require a co-payment, is one of those where we will eliminate the cost sharing. Things like glaucoma screening, which again requires cost sharing. The calculation has been made that if we cover that cost up front, we're going to see dividends down the line because of the preventive services that it will lead to. And we are bringing the same kind of thinking into this new health insurance exchange that's going to be created. For those of you who haven't followed the debate as closely as others, you know, we have 47 million Americans who don't have health insurance coverage by most estimates, others who are underinsured. But the way in which we are going to address the problem of the uninsured is twofold. On the one hand, we are going to increase Medicaid eligibility to 150% of the federal poverty level which will bring in millions more who will then be covered under the Medicaid program. Secondly, for those between 150% of the federal poverty level and 400% of the federal poverty level, we're creating this health exchange where people can come into the exchange armed with their own resources plus affordability credits that the government will provide in order to purchase coverage from either private health plans or a public option, if a public option is in the mix, and I advocate that, and be able to benefit from the sort of pooling and group coverage that normally they would not have access to. In that exchange, we're going to require that a number of preventive services be covered without a cost-sharing obligation, again, because we see huge benefits. Let me just, because I don't want to miss the opportunity to do this before the questions end, let me name some other things which directly connect to enhancing preventive services. So I've just talked about the cost-sharing. The bill is going to expand the capacity of 2 independent advisory task forces. One is the U.S. Preventive Services Task Force. The second is the Task Force on Community Preventive Services, enabling them in an independent fashion to do a lot of very rigorous and systemic review of the existing science so they can come up with recommendations. Very, very important that we have that done. Third, provide new investments in the science of prevention. See, for the very reason I mentioned at the outset, so the CBO can't sort of cast it aside as, witchcraft or something. You've got hard, definitive, empirical data that then can be linked to the economies that you generate there and shine a light on how much savings is going to be generated. We're going to deliver community preventive services by investing in state, territorial, local public health infrastructure. I mentioned the community health center expansion and upgrade, expanding preventive services at FQHCs, federally qualified health centers, in terms of reimbursement for a broad array of services that are not now covered. A grant program to help small and mid-sized employers begin strengthening workplace initiatives with respect to prevention. And many other initiatives, again, that are going to shift the system, the emphasis of our healthcare system, in a different direction. And we just haven't been able to take advantage of that because the current powers that be have tied us in knots for so many decades. And so your day is coming, it really is. And I'm going to work as hard as I can to make sure we don't miss this opportunity. Any other questions? Yeah.
As we continue to take questions, if you do want to email your questions in, I encourage you to go to our site, maphtc@jhsph.edu. Young lady in the black.
Thank you. I'm Laura. This bill is really great news, and thank you for your personal work on it. One thing that happened late on Saturday, though, was the Stupak Amendment, which prevents any government-subsidized plans from covering abortion. I'm wondering what you think is going to happen with that, what the Democrats have decided to do about that issue, if there's any way to move it forward, given how contentious it can be.
Well, I appreciate that question, because nothing could be more relevant to public health than the issue that you raise. And what the questioner is referring to is there was an amendment that was voted upon just prior to the bill's passage on Saturday night, which was offered by Bart Stupak, who is a member actually of the Energy and Commerce Committee where I serve. He's a member from Michigan. He's one of a number of members, many on the Republican side, but a significant handful of members on the Democratic side as well, who has pushed consistently to resist any abortion services in any of the various health bills that we have. Now, he he recognizes the current law with respect to the Hyde Amendment as a general matter, where public funds are not permitted to be used for abortion coverage except in the case of rape, incest, or threat to the life of the mother. But as we began to have this discussion of the insurance exchange, the health exchange rather, where the uninsured could go purchase services and where government subsidies, i.e. taxpayer dollars, would be in play, there started to be much more focus on this issue. And it really intensified over the last few weeks and kind of broke out into the open last weekend. I will add, with a significant amount of lobbying and advocacy from the Catholic bishops on the issue. And what the Stupak Amendment ends up saying, and the process, sadly, was this. We were attempting to negotiate a compromise between the sort of different camps on this question, and that broke down. And in that vacuum that was created when the discussions broke down, Stupak came forward with a very aggressive proposal. What we had worked out in committee, we thought, was to create a mechanism whereby insurers who offered coverage in the exchange would segregate public dollars from private dollars. So in other words, you're going to have millions of people coming into that exchange, potentially tens of millions, who are going to have some of their own resources that they can commit to their coverage expense, but are going to need to use these affordability credits, up to 400% of the federal poverty level. You qualify for those in order to buy their coverage. So you have public dollars coming in for that coverage and private dollars. So we had created a mechanism whereby the insurers would segregate and they would pool the private dollars one place and the public dollars another place, and any abortion coverage that was sought would be paid exclusively from the private pool. By the time we got to the debate around the version that would go to the House floor, that was not satisfactory to the advocates and to the bishops and others who were making the case. And so these negotiations began. And when they broke down, what Stupak proposed and what was passed as an amendment, I voted against it, but what passed was a limitation that said that any insurer who provides coverage in the health exchange, who wants to have access to those people that are coming with affordability credits, cannot offer abortion coverage, which means that even though technically, legally, you're not banning that kind of coverage, you're ensuring that any plan that, as a business matter, wants to be viable in that exchange is not going to offer it, because no health plan is going to make the business decision to forego those millions of people who are coming with affordability credits. So given the choice, they're not going to provide coverage. So anyway, I voted against that, but then it passed, and we had a judgment to make on final passage. And even the most fierce pro-choice advocates in the chamber and the groups, the advocacy groups around the country, recognized that there were so many other benefits in the bill that we should not, on that basis, vote against the bill. Now, my hope is that there's been enough attention now drawn to this that there will be some very intense advocacy over the next few weeks, and that the Senate version of the bill will push back in the other direction. We'll get to a reasonable compromise that I'll feel more comfortable with, and I assume you'll feel more comfortable with, and that's what we can bring out in the final version of the bill. It's worth asking yourself, because people will pose this question, well, if the people going to health insurance exchange are folks that aren't getting any coverage now, then they're not going to be any worse off because abortion services aren't covered there, right? Because they're not getting coverage for anything now, including abortion services. At least if they go into the exchange, they will get it. The problem with that is people get services often, they get access to services anyway based on their income. And so it's fair to assume that the losers are going to be people who are of modest or low income when it comes to accessing those services. Number one. Number two, the exchange permits small employers to come into the exchange and seek coverage for their employees. And I'm sure there are many small employers right now, 20, 30, 40 employees, including female employees, who are trying to cover, they're paying these health plans, trying to cover those folks. And they have plans, because 85% of private health plans cover abortion services. They cover that service. If they have to move into the exchange because they just can't handle the cost anymore, now you have a situation where 20 or 30 people in the workforce, and let's say half of them are women, had access to that kind of coverage before, have now lost it in the exchange. So anyway, very good question. Very, very intense passions, obviously, on all sides with this. I hope we can bring the changes that I just mentioned to you as we go forward in the process. Next question.
I'm Jordan Cooper. I'm Jordan Cooper. I work for the Maryland General Assembly. I hear that America's healthcare system is providing inferior care at a greater price than other post-industrial nations. So I see a lot of legislation targeted towards expanding coverage and reducing costs. But what sort of provisions are being discussed to improve the quality of care, especially in consideration of the shortfall of primary care providers?
Right. Well, I think much of the impulse and what's actually happened in the bill, when you look at its provisions, are designed to focus on quality of care. There's been a lot of research, and you may have read some of these stories in the New Yorker by Atala Gawande, who's really made it his crusade to expose this, that more care, for example, doesn't necessarily equate to better outcomes. And he has compared different models of delivering care around the country and been able to demonstrate that some of the places that have the most cost-efficient approach to care are actually delivering the best outcomes. That has led to intense interest and research and just curiosity, I will tell you, on the part of many members of Congress to understand this better, because we've gotten ourselves used to the idea that if you do more tests and you spend more money on the care, you will get a better outcome. There's actually research that says not only is that not the case, but in many instances, the more care you provide, the worse outcomes you're getting, because you're not approaching often the treatment in a holistic fashion. So I would say there's a lot of attention to the quality of the outcome, and one of the things that this bill does is mandate that the Institute of Medicine, existing studies that have been done by the Institute of Medicine, as well as others that will be commissioned, that the recommendations that flow from that in terms of what Medicare will reimburse for and what models of care will begin to prevail, a lot of that will be based on looking at this issue of quality. Let me give you one example. There's something called accountable care organizations, which is a model that's begun to be tried and showed some real, positive developments. It's not a panacea, but the idea is let's start rewarding physicians for managing the care they deliver more efficiently and demonstrating better outcomes. Let's actually reward them financially for doing this. So it puts together a model that can do that. Think of it this way. Instead of the management of care being done at the insurance plan level, where the dollar gets stuck there, allowing the plan to sort of skim off the top, the profit, and then pay what's left over to the provider. Think of this as the dollar flowing through there or bypassing that bottleneck and going directly to the provider with the opportunity for better reimbursement, better compensation, based on demonstrating better outcomes and employing more innovative models of managing care. A lot of investment and attention to that. And when you think about it, this is the direction we ought to be moving in. We can deliver the best care in this country, but we have not figured out how to deliver it in a consistent fashion, and that's what the new healthcare system is going to have to demonstrate if it's going to make a real difference. Other questions?
I'm going to also build on some of the.
Okay, I think we got one there.
Hi, my name is Keisha.
Hi.
I'm a nurse here, and I work in the School of Public Health. And I just wanted you to speak a little bit more on, when you were talking about prevention, you mentioned how the CBO doesn't score prevention very well, and you talked about, you mentioned nurses, part-time nurses who aren't available in schools and how that affects H1N1. Are there other examples that you could talk about or elaborate on more that possibly could get the CBO to take a better look at this, especially in light of H1N1 as a clear example?
Well, I think there have been demonstration projects up till now, and we tried to point the CBO to some of these and ask them to extrapolate more broadly in giving us credit for some of the prevention initiatives that we wanted to put in place. But they determined that those weren't conclusive enough, or they weren't broad-based enough to justify that kind of credit. I can assure you that even though we didn't get credit for them, notwithstanding my example of what happened with the school-based health center, we are pushing forward, and based on the outcomes of those the demonstration projects, investing a lot of resources in this because we really do think that it's the right thing. And in addition to what I think is hard empirical data that for some reason they won't give credence to or enough value to, there's so much anecdotal evidence that is the right way to go, both when you talk to providers and when you talk to patients, that we can't miss the opportunity to test this more broadly. You look at other nations around the world and the investment that they are making in front-end treatment and prevention, and they're spending much less on a per capita basis for health care in their societies than we are. I mean, it's almost embarrassing. It's like we're the last kid in the class to figure out the formula on the board. Everyone else seems to be getting with the program. Now, I do want to mention that we have to design a new system from where we are. It's very difficult to throw everything out and start from scratch. And Gawande actually analyzed 5 or 6 universal coverage systems around the world. And in every case, it was not that they appointed a blue ribbon commission and came up with 4 or 5 options for how you design a healthcare system and said, we want that one. It was always particular events or conditions that existed in the country at a particular moment that caused them to move in that direction. So in England, it was during the war that you moved to the national health system because they moved a lot of families out of the cities because of the German air raids, and they needed a way to provide care to them, so they hired physicians directly. They had contracts directly with hospitals. Lo and behold, at the end of the war, they looked at their public health data, and it improved dramatically. And the population had gotten used to those services being delivered that way, so then they built from there. So we have to build from where we are. An example of that on the prevention side is community health centers. If they are really given the resources and the attention and the support that they deserve, and we expand that network, I think it's going to make a tremendous difference for millions of families across the country. So that's building from something that we have and building in the right direction.
if I could segue from your comment
Sure.
on community health centers actually to a lot of the good work done by the U.S. Task Force on Community Preventive Services are really not patient-based. They're really community-based, and therefore the funding for them would not flow through the health care system.
Right.
Although the outcomes obviously are health. How would that money flow?
Well, that's going to flow directly through, outright, ongoing government support through grant programs that will be established. And, through these grant programs, a lot of times you can incentivize people to innovation. You can say, look, there's money available. Here's a pot of money that's available if you will try certain innovative practices. And we've built that kind of incentive into the bill with respect to some preventive health care and public health initiatives, again, based on good research and results that are already out there. That's what's so maddening about this. We don't have to reinvent a lot of stuff. You know what it is. You know what the research shows. It's just a matter of implementing it. But you made me think of something else, which is that there's a concept called the medical home, which has generally been referred to when you think of an individual patient, that individual patients need a medical home. So if you're a senior who suffers from 3 or 4 chronic conditions, you may be seeing 4 or 5 different specialists, but nobody is stepping back and coordinating that care, looking at the interplay between the various physicians in the mix and the services that they're delivering, with potentially disastrous results for the patient and obvious cost implications, okay? So this concept of creating a medical home for the patient, and that's where you're investing in the primary care approach. Somebody who's up at 10,000 feet and sees how the services are being provided to an individual patient, that can generate better care for the patient and better cost savings for the system. But we can also think of medical home in terms of community medical homes. So when I think of a school-based health center as the medical home for a community of students that are in that school, right? I think of services that are provided at a senior center to seniors, more primary care services and so forth. That turns that senior center into a medical home for that community of seniors. And obviously community health centers, by definition, represent a medical home for the community that they serve. And your point's just very well taken, because we haven't invested in the perspective of what it means for a community to be well. We're very focused on the individual patients, but we don't think about what it means for a community to be healthy. And you can take the community as a whole, or you can slice it into different, categories, if that makes sense. But that community approach, that is what undergirds a public health system. If you don't bring that community lens to the idea of providing health, then you won't ever get to an integrated, comprehensive, and effective public health system. So those are some of the things that we're trying to explore in this.
We'll take our last question from
Okay.
our internet.
Okay, and this is not one of your constituents, but it's a fellow preventive medicine resident from Stony Brook, Long Island, who writes to ask you, what provisions in the bill advocate for the lower middle class small business employees and small business owners who do not generate enough income to afford to provide private health insurance, but won't be able to qualify for the public assistance? And how does the current administration plan to reach those employers and employees?
Well, let me say at the outset of answering that question that when people say to me, well, is this bill going to help small businesses? My response is that much of the impetus behind the bill was to help small businesses. I mean, this wasn't an afterthought, okay? This was like one of the 3 or 4 major objectives behind health reform. One being universal health care coverage, another, I think, being orienting more towards keeping people healthy rather than, looking after them on the back end. But a third, among a number of key ones, being this idea of helping small businesses, which are just getting crushed right now. 27 million of the 47 million people who do not have health insurance coverage right now are small business employees or proprietors and owners of small businesses. So right out of the gate, by addressing the problem of the uninsured, you're helping small businesses. Small businesses currently spend 18% more on their premiums than large businesses do for the same exact benefits and coverage. 18% more, because they're not able to access the pooling mechanisms that large employers are able to access. So much of the reason behind creating the health exchange was to give small businesses a reasonable option for getting affordable care. And the estimates and these are by the economists and by the Congressional Budget Office, that out of about $2.7 trillion cost over the next 10 years in terms of what small businesses spend with respect to obtaining coverage, we can save with the new regulatory parameters we're putting in, with the health exchange, with better pooling of group coverage, we can save those small businesses over the next 10 years about $800 billion. So you're talking about $80 billion a year. Now, under the exchange proposal, beginning in 2013, when the exchange comes online, I believe small businesses with less than 20 employees will begin to be able to access the exchange. In the next year, it goes, I think, to 50. The third year, it may even go to 100 and less. In addition to that, for a period of 2 years, small businesses will get a 50% tax credit, a tax credit equal to 50% of their cost of purchasing the coverage for their employees. So this is also going to be a significant help to them. So it's not just that small businesses benefit from this bill. They were one of the main beneficiaries we wanted to have addressed in this bill. And I think, notwithstanding, for example, the National Chamber of Commerce, which has taken a resistant, sort of oppositional stance on the health care bill, you talk to a lot of the smaller chambers of commerce across the country, and when you explain the bill to them, they say, this is going to represent a wonderful, wonderful opportunity and relief from current conditions that just absolutely cannot be sustained. So I think there's a lot of really positive things in there for that community. And is that our last question? Okay.
Unless someone has a burning question.
Oh,
You have a burning
is
question.
it burning?
Yeah.
Okay. Okay, well, if you've had it for a while, it's burning by definition.
Okay, so my question pertains to how people are going to navigate the exchange. First off being how many insurance companies will be involved in that.
Mm-hmm.
I think about pensions versus 401ks and some studies which have shown that state employees enrolled in pension plans do much better financially than those who are navigating the 401k system themselves. So I'm just wondering who's going to help people figure all of this out.
It's a great question. There has to be an education piece of this, an information and transparency piece once we get it in place. Now, there's a couple of reasons why the exchange doesn't kick in until 2013. One is it's going to take a couple of years to get the structure of it developed. But I think we can also use that time to educate people on what their options are going to be and what the process is going to be. Unlike, for example, when we put the Part D prescription drug plan in place, and it was just this sort of blizzard of choices available to people. I'll never forget it. At that time, I was chair of the healthcare group at my law firm. So I said, what we should do? Let's order out lunch, and we'll sit down, And we'll spend, an hour, and we'll go on the Medicare website and, figure out once and for all exactly kind of what's going on with the Part D program. So we had about 100 years of accumulated healthcare experience in that room. And after an hour and 15 minutes, we just gave up because we couldn't understand it, let alone, a senior sitting at their kitchen table trying to navigate that. Now, there are other reasons why that program had problems with it. But even in the best designed world of this health insurance exchange, this health exchange, we are going to need to really educate people so they can make good choices when they get in there. The choices that will be available to them are most private health plans that we expect will want to come in there because there's millions of potential enrollees that are going to be available to them, as well as, I hope, a public option. And let me just close with a plug for the public option. First of all, unlike what the critics suggest, the public option is not going to, take over the universe. It is an attempt to provide some competition for the private health plans out there. I think, frankly, can be a place where more innovation is modeled. That's not associated with government plans, but look at some of the things Medicare has piloted. And I think you could see a similar thing happening with the public option, which will be a non-profit plan, will not have that profit motive, has demonstrated, I think, through programs like Medicare that it can keep its overhead costs relatively low. And so it ought to be in the mix. And let me just note something that was discovered in a survey they did, which shows how smart Americans are when it comes to this healthcare debate. They did a survey and they said, do you support the idea of an individual mandate, which is a requirement to purchase insurance coverage to kind of get rid of the free rider problem, make sure everybody is paying into the system. And they said, well, we're not so sure that people ought to be forced to buy coverage. And then they said, well, what if there's a public option available? And at that point, a clear majority said, no problem. Now think about that for a minute. What they were saying was, don't force people to go buy insurance coverage if they have to purchase it from the same old pack of wolves. But if you actually give them a reasonable set of choices and options, then it's a request that makes some sense. And that's what we're trying to provide to people in this bill. We're trying to provide them with a good set of options and choices. We're trying to provide them with a healthcare system that's going to be focused more on keeping them well instead of just getting them better after they've already gotten sick. And, as a father of 3, I think we're trying to provide a healthcare system that will be good for our children and our grandchildren. And we've really not done that up till now. And we can do it. And look at how much we've achieved as a nation, even while we were carrying this broken healthcare system around on our back for decades. And imagine the heights we can reach as a society and as a people if we fix this problem. Think about that. Think about if you could move jobs, if you could accept that promotion to go up the career ladder by going somewhere else without having to worry about and ultimately make the decision not to take that new job because you're concerned that you won't have health care coverage or a pre-existing condition will not be covered under that new policy. Talk about distorting the economy and tying us in knots. What if we didn't have to deal with that? Imagine where we could go. But we've been like tying our hands behind our back as a society with this thing. We got to beat it. We got to do this now. And that's why we're going to keep pushing for it. And I appreciate the opportunity to talk to you about it today.